All right, good morning, everyone. All my respiratory therapist friends out there, whether you are getting off of work, about to go to work, it's an off day, you're a student, you're a physician, pulmonary function technologist, it is my pleasure to be here today to present to all of you about the present and future pulmonary diagnostics. I would also like to thank Respiratory Associates for allowing me to have this opportunity to present in front of everybody today. My name is David Westenkirchner. I am a respiratory therapist. I have been going on as a respiratory therapist now for about 15 years. 10 of that was about bedside clinical specialist at an ICU level care children's hospital in Indianapolis before moving into the medical device world. I did a little bit of a stint for a ventilator manufacturing company during the peak of COVID. I worked for Olympus during the respiratory division before moving to 4D Medical. Now I am the director of clinical products here for 4D Medical. So as a quick disclaimer, I am employed by 4D Medical, so just wanted to get that out of the way. But let's talk about the objectives that we're going to cover today for today's presentation. So there's essentially three objectives that we're going to be getting into. Number one, we're going to understand the current state of pulmonary diagnostics and some of the drawbacks to each of those modalities. Just kind of a general overall view of what the current modalities in diagnostics and pulmonary are. Then we're going to talk about the introduction and the incorporation of imaging modalities as a complementary tool to diagnostics that we have today. And then on top of that, with leveraging imaging modalities, being able to utilize not only mathematics from some of the algorithms, but also AI enhanced algorithms that allow you to see just a little bit further beyond what current diagnostics are capable of doing today. So as far as the current state of pulmonary diagnostics is concerned, there are essentially kind of four big buckets that we're going to put everything in. The first is going to be spirometry, pulmonary function testing in general. This is the current benchmark in lung diagnostics. It's essentially great for showing us lung function, but not the best at looking at lung structure. Pulmonary function testing is insensitive. What that means is it essentially quantifies the entire lung as one kind of average measure. It's non-specific. We need up to around 20% invariance for one of our metrics from pulmonary function testing to be clinically significant, which can essentially result in late or lagged diagnosis. Pulmonary function testing can be time consuming, and it's not necessarily available to all patient cohorts. In particular, pediatrics are those that are not able to do pulmonary function testing due to their disease state. Next, we have X-ray technology. So now we're getting into some structure, but we're not looking at pretty much anything for lung function. It's inexpensive, which is great. It requires little radiation, but again, it doesn't tell us much about airflow and lung function. And sometimes overlapping structures can hide features, and chest x-rays are not necessarily useful as a screening tool. So let's bump it up to the next level, looking at high resolution chest CTs. So again, we're not really looking at lung function, but we're getting a much deeper look at lung structure. It's three-dimensional, it's sensitive, but it requires a higher dose of radiation. It's a higher cost compared to a chest x-ray. And as I said before, we're still measuring structure over function. And last but not least, we start moving into nuclear medicine. For nuclear medicine, we're looking at some lung function, and you could argue we maybe be looking at some lung structure, but that's not necessarily the primary goal for nuclear medicine. But with nuclear medicine, we are now able to kind of take a peer into the other side of ventilation, and that is perfusion. We're now able to, through nuclear medicine, identify ventilation perfusion mismatch, but nuclear medicine is at a high cost. It essentially has relatively poor resolution. It can be time consuming, and it requires the use of radioisotopes, those that both need to be injected and inhaled. And if your hospital or your facility doesn't have a nuclear medicine department, this is just not able to be performed at all. So looking at all of these all together, the above existing imaging modalities don't necessarily offer us an objective insight into lung function. So again, just to recap, current modalities on the left, we have a CT scan, three-dimensional image, useful for structure, but no real function. On the right-hand side, we have spirometry. It can measure airflow from the lungs, but it's a single global measurement, providing some function, but it limits us to know what's going on in regional areas of the lungs. And then in the middle, we have 4D CT, which is a video sequence in 3 dimensions of the lungs. It shows us how structure changes over time from breathing, and it contains a lot of information, but this is rarely utilized because there's also a lot of exposure to radiation. And this is where some of these new technologies are going to come into play, starting with XV technology. So XV technology, what is that? XV technology relies on a technique that's known as computed tomographic X-ray velocimetry. So the XV in that is X-ray velocimetry. And we utilize CTXV, which combines particle image velocimetry. So it's a technique for extracting motion from a video sequence of a fluid flow, and computed tomography. So we're essentially combining these two, particle image velocimetry with CT, which is a technique of taking 2D X-ray images from various angles, and we construct them into a 3D image. So we have XV technology. So how are we actually extracting the information? So we have the patient that is getting fluoroscopy from 5 different angles. So essentially fluoroscopy is just video X-ray. And then we combined it with a prior chest CT for the structural information, and we put them together. So how do we take these videos of the lungs breathing and extract the same amount of information as if we were actually measuring airflow from pulmonary function testing without measuring airflow? So the way that we do this is we utilize a technique called mathematical modeling. And so we just mathematically model the system. So how we do this is we take a real world system, so the physiology here of the lungs, we translate it into a mathematical language, we solve for all things using mathematics, and then we interpret that back into a real world system, such as the report that you see here on the right-hand side. So mathematical modeling, are we using something like that today, perhaps right now, at this very moment? I bet those of you that are in attendance at home, you either have it on you or it's within an arm's length from you. Anybody that has a cell phone, that has a camera, we are using mathematical modeling almost every day. And we do that through image processing. So image processing is one such example of mathematical modeling of a real world system. So an image, spoiler alert, this is a picture of Abraham Lincoln. This is just an array of pixels. That's all it is. We could sharpen this, sure, but when it comes down to it, an image is just an array of pixels. Each square is a pixel, and that square is just a color representation for a number. So darker pixels are going to have a lower valued number, brighter pixels will have a higher valued number. So now we have an image that we've broken down to pixels, that we've associated those pixels with a number based on their brightness. And now all I need is just an array of numbers that I can work with instead of just the image itself, requiring far less data. So the way we can manipulate images with image processing, this is just an example, right? So an example, we have an image which is just an array of numbers. We can add or subtract something to those numbers to affect the overall outcome. So for example, here, if I add 64 numbers to all of the numbers, it brightens the image. And if I subtract 64 from all of the images, it darkens the image. And the same thing can be done with blurring. So this is a similar process for image processing. This time we just replace each pixel with the average of the pixels around it. And the more pixels we average, the blurrier the image becomes. And again, this is just an example of taking an array of numbers and we perform mathematical operations on those numbers to affect the outcome. So particle image velocimetry is a technique that we use for modeling fluid motion. So here is a video of some fluid and it's sloshing around in a container. And in order to model what this fluid is doing, we can see the surface, absolutely can see at the surface what's going on and what it's doing, but we're only able to tell if the surface is moving up or down in a certain location. But if we were to look at the fluid underneath, down here below the surface, it is almost impossible to tell in what direction or how that fluid is moving. If we had to try and model how this fluid is moving, one piece of information that we could take away to give us a general idea would be the motion of the bubbles that are moving around. So you can kind of tell that at the surface, we see a bubble over here on the right-hand side. We can see from that bubble, it's moving up or down, just like the surface is moving up or down around that bubble. So it's kind of, the bubble is kind of giving us some idea of what the fluid is doing around these moving parts. And this is where particle image velocimetry can help out. If we took this fluid and we filled it with particles that are roughly the same density as the fluid itself, or for this example, water, we could then assume that the particles moving in the water are representative of the motion of the fluid around that spot. And we can take a video of the fluid and track where those particles are moving to figure out how the fluid around that particle is moving at any given time. So I know it's kind of hard to think about, what does that look like? So here's an example. This is a general setup for what particle image velocimetry looks like. And the setup can vary depending on what the experiment is looking at, but for the most part, we have a fluid in a sample, which has been seeded with particles of the same density as the fluid. We have some sort of illumination source. For the example here is an X-ray beam. It can be a laser. And then we have a camera, and the camera is capturing the motion of the fluid and these particles. And so you can see what that would look like over here at the right-hand side. And so now from the video on the right-hand side, we can get a much better idea about how that fluid is moving compared to looking at how a fluid is moving like this. Right? So we can't really tell what's going on here. This is giving us a much better idea of how the fluid's moving. So now that we can visually see a little bit better about what the fluid's doing, we can start to look at how would we actually track each part of this and how the fluid's moving to model it mathematically. So this is how we are going to check that out. We're going to look at one square in this entire kind of image, one frame of reference in a point of time, and we're going to lay a grid across the entire frame, and we're going to look at one square. And in the very next frame, so going from time of 0 to some time afterwards, whatever that may be, whether that's a millisecond, half a second, a whole second, 10 seconds. In the next frame, we're going to look at the region around our initial frame of reference, where we're trying to look to see what's the best match to this initial patch that is moved into the next frame. Now, it won't be in the exact same spot, and some of the particles may have strayed, so they won't move all exactly the same. But on average, they should move roughly similar if we choose the size of squares that's appropriate. And then we can figure out where the motion went from frame 1 to frame 2 based on seeing the particle motion. So to make this a little more simple, we have a group of particles in one image at time of 0. And then in the time after time of 0, we see that the particles have shifted. We can now find this shift, and we can say that on average, the motion within this square of fluid is represented by an arrow or a vector. And then we can go back to the initial image and do that for every single square that we want to look at. And so what does that look like overall? Looks something like this. So again, now we have a laser, we have our fluid that has been seeded with particles, and now we're looking at each frame of reference and comparing the motion or vector of the particles in that frame of reference across every single square. And this builds us an array with vectors that show where the fluid is moving so that we can actually model the motion of the fluid. So if you are sitting there watching at home, you're saying to yourself, well, we're not even talking about the lungs. In fact, we've strayed pretty far from talking about the lungs, and we don't actually see the lungs using any sort of particles. We're not having the patient breathe in or get injected with anything. They're not breathing in any special type of gas. So how do we do something like this with videos of the lungs? And that's where we use an image processing technique. So the images of the lungs on the left, we use image processing to essentially remove things that we don't want to look at. We're going to take out the ribs. We're going to remove the heart. And we're going to enhance the lung tissue to produce what we see on the right-hand side. And this setup, although it's not exactly like particles, this texture represents something very similar to the particles, where now instead of tracking particles, we have this texture-enhanced lung image. And now we can track where this texture moves from one frame to the next and extract motion from these videos with this sort of texture field. And we would do the same thing like we were looking at for the particles. We're going to lay a grid on top of the lung field, and we're going to have each of these squares where we can now track where each piece of this tissue moves from one frame to the next. And we do this for all the frames on the squares, and we end up with arrows which indicate where each one of those patches was moving, where those squares are moving. And this is how we can extract lung motion from just video sequences of the lungs. And this is what a motion field would look like. And then we have each of this for each one of the angles from our fluoroscopic images for each frame in time. So now we'll have a moving sequence of these arrows that can describe the motion of the lungs. So here we have our patient who has undergone fluoroscopic sequencing from 5 different angles, which looks like this. And we'll take each of those video sequences and we'll process them. So now we have lung enhanced texture fields from those same 5 different angles to create vectors that are indicative of lung tissue displacement. So now we're starting to get into, again, back to the image a couple slides ago, XV technology. So we require 2 inputs. We need fluoroscopic images from 5 different angles, and all we're having the patient do is breathe regularly. They're just doing tidal volume breathing on the fluoroscope. And we need a prior chest CT for the information for the thoracic kind of cage. We need to know what is the boundary in which all of this motion is occurring. So now we can co-register the motion from the patient's tidal volume breathing from fluoroscopy into the space that the lungs occupy so that we can track the lung tissue just within that space. So now we have our vector field from each of the 5 different angles. And now we have our reconstructed 3-dimensional thoracic cage. And so now what we have here is we actually require much less information from just raw images when we've turned everything into motion fields and a 3-dimensional cage. And now we can reconstruct this motion because the boundaries are known. And what we end up with, you have 5 video x-rays, different angles. We extract the motion from each angle. And using the knowledge from the CT of where the lungs reside in a 3-dimensional space, we can now construct a 3D motion field to look at the actual motion of the displacement of ventilation across the patient's lungs from video images. So XV technology, in kind of layman's terms, essentially is only 4 steps. You have your scan input, which would be from the fluoroscopy. And then essentially what we will do for image processing is we will overlay these voxels. So a voxel is a 3-dimensional pixel across the entire lung field, and we will see where did those voxels start at the beginning of the breath to where did they end up at the end of the breath. And then based on that voxel motion, we'll use that as a surrogate for tissue displacement, and we can quantify the motion. So we look at all the voxels and we average them together, and then we can compare each individual voxel to the average. And the ones that didn't move very far at all will show up as red. The ones that were closer to the average will show up as green, and the ones that moved a lot are going to show up as blue. So in other terms, to be able to see what this looks like, we're going to utilize something called LVAS, Lung Ventilation Analysis Software, and it looks like this. So now we're actually able to see in real time the distribution of ventilation across a patient's lung field. So now we're looking at it from 2 different angles. This is a coronal front to back view, and this is an axial superior to inferior view. And you can kind of see down here, we're starting at the beginning of the breath towards the peak of the tidal volume breath. Everything starts off as red because there is no ventilation moving into the lungs. And then towards the end of the breath, some things are green, some things are blue. And it's just showing us the difference between where has the ventilation gone in the patient's lungs during their breathing. And we've been able to take this XV technology algorithm and apply it not only to fluoroscopy, which is not readily available or very available throughout most hospital systems, but we can apply it to another more commonly used modality, which is computed tomography. And so some of the information that you can get, so we have XV-LVAS, which is based off of fluoroscopy, or CT-LVAS, which is based off of CT. And when a report is generated for the physicians, we have this kind of executive summary page, which shows a coronal slice from both of the images with 3 corresponding upper, middle, and lower third axial slices. And I'm just showing the comparison here to show that the fluoroscopy data and the CT data look very similar. We also move into not only just pictures, but quantitative data as well. So for both the fluoro input and the CT input, this is actually a graphical representation of the distribution of all those data points across the entire lung field. And we can see this is how we get our color coding for those specific voxels. So essentially all the voxel data points throughout the entire lung field, we'll add them up. And when we get the average is right in the middle at our 1.0. This is where the voxels get assigned that green color from the images here. And so the voxels that move further or further displaced go off towards the blue. This is indicating compensation across the lung field. And the voxels that didn't move very far, the tissue didn't displace, indicates areas of little to no ventilation. And if they are low enough, they fall into ventilation defect percentage, which is essentially going back to the images and adding up all the voxels that were red. And this is a biomarker that we've borrowed from functional MRI. It's just using a different modality to get to it. Some extra quantitative metrics that you can also receive from the fluoroscope. We can generate our tidal volumes. And from the CT, because we are doing inspiratory and expiratory breath holding for our patients, we can look at their expiratory volumes, the inspiratory volume, and their change in volume. And both modalities show us ventilation heterogeneity, which is looking at the evenness in the distribution of the ventilation across the entire lung field. So what is the clinical utility for using a technology like this? First off, it is a validated assessment of regional lung function. And when I say validated assessment, this was validated based on pulmonary function testing. What the studies were able to show is that the quantitative metrics from XV technology, ventilation heterogeneity, so the evenness in the distribution, and the defect percentage, the areas of red, when these numbers begin to decrease, which indicates an improvement in lung function, there was shown to be a correlation to FEV1 and the FEV1-FVC ratio. We also have a reliable repeatability of findings, where this is a healthy male in their mid-30s. This is their initial scan. We see both radiographic coronal slice on the left with the ventilation overlay on the right, and this is 3 months later. Now, whether this was 3 months later, a day later, the same day, what we would expect for a healthy patient where we haven't changed anything with their lung health, we haven't given them any more medications, they haven't gotten sick, we would expect to see that there is not a big change to what their scan should show from a day to day or first day to 3 months later. So what we can see here is radiographically, there's really no difference. And even on the ventilation overlay images, there's no difference either. And the quantitative metrics didn't show any statistical significance from scan to scan. But we're also able to use this technology to quantify regional ventilation defects. And this is something that pulmonary function testing cannot do. Again, as I said in the beginning, pulmonary function testing kind of creates an overall average of lung function, and sometimes that can lead to late or misdiagnoses because the patient may be asymptomatic or symptomatic, but they haven't gotten to the point where it shows up yet on their pulmonary function testing. So this is an interesting case. 36-year-old man that had developed severe progressive silicosis, worked as a stonemason for 10 years. And a hallmark of silicosis is typically there's fibrotic tissue that starts to develop, especially in the apices of the lungs. And so we have an initial scan at the top, and we have a 3-month follow-up post-treatment scan at the bottom. And this patient was looking for some type of relief for their work of breathing. So they underwent an experimental treatment known as whole lung lavage. So essentially the patient is sedated, intubated, and then their lungs are rinsed out with saline. Everything gets sucked out. And what we can see from the initial scan on radiographic information to the follow-up scan is that there really does not seem to be a change radiographically, or there may even be a little bit of a worsening of the fibrotic tissue. But that did not correspond to how the patient subjectively felt about their work of breathing. They felt their work of breathing had improved. And we can see the initial scan, the right upper lobe is not contributing much to the ventilation. It's all red. In fact, the air that should be going to the right upper lobe is being compensated for by the left lung. And the ventilation heterogeneity and VDP markers are elevated. 3 months post-treatment, the right upper lobe has turned green and has come back to normal, even though we still have a little bit of compensation occurring in the left lung. But both of the markers for VH and VDP have decreased, indicating that there was actually an improvement to the patient's lung function. So this technology also offers us an effective monitoring of disease and treatment effects. And it doesn't necessarily have to be a silicosis patient. This could be an asthmatic, a COPD patient, or a cystic fibrosis patient that perhaps is trying new biologics. It can be utilized as a non-invasive method for validating the effectiveness of a pulmonary rehab treatment. There are multiple use cases for how this technology can influence the course of longitudinal tracking for disease progression and treatment monitoring. So up until this point, we've mostly talked about functional lung analysis. And we've talked about both from a CT modality and from a fluoroscope modality. And these are actually mathematical algorithms. So we've only been talking about just crunching the numbers. We haven't even begun to leverage artificial intelligence in some of these algorithms. So what about AI and machine learning and deep learning. So when you start to incorporate some of these things into imaging modalities, now we have the ability to look at not only functional analysis, but also structural lung analysis. And AI comes in a variety of quote unquote flavors, with the most prominent being machine learning. Machine learning is a broad category of artificial intelligence where computers essentially learn from data without being explicitly programmed. So it includes many types of learning techniques like decision trees, we have linear regression, and deep learning. So deep learning is a type of artificial intelligence that teaches computers to learn from an abundance of data, essentially how human beings learn from experience. Instead of programming the computer with the rules, we feed it examples and it figures out the rules on its own. So we already talked about CTLVS and XBLVS, which utilize mathematics, but some other technologies that are out there, some other algorithms that can look at structural lung analysis, such as IQ-UIP, this is using deep learning for the recognition of UIP pattern amongst inspiratory-only chest CTs to be able to flag quicker for ILD specialists to lead to an earlier diagnosis for idiopathic pulmonary fibrosis. We have lung texture analysis, which is utilizing machine learning for fibrotic tissue detection and also the characterization of that tissue. And then we have lung density analysis, and this is a complement to the structural information of tissue that we're already being provided functional analysis from CT and XV-LVAS. And it does this by using deep learning for lung and lobe segmentation, and then also classifies it utilizing something called Hounsfield thresholding. So now we're going to just go into these two examples of lung density analysis, which give us our structural lung analysis. So again, CT and XV-LVAS were giving us regional functional information on ventilation. LDAI, so inspiratory only CT, or LDAF, functional lung density analysis, give us structural information about the health of the lung tissue. And now we're moving away from looking at voxels, but now we're actually going to be doing it in a different kind of way, utilizing something called Hounsfield thresholding. So we talked about this before. You have a pixel, which is just kind of a two-dimensional object on a flat plane. And if we're looking at voxels, we now have a three-dimensional pixel. And Hounsfield units are something that occurs on chest CTs or any CT that essentially is looking at the image grayscale. And it's looking at going from black all the way to white. And the area that we're concerned with when we're looking at lung tissue is kind of this little window right in here, essentially anything from about -1,000 to about 0. So if I was to take this little section, kind of blow it up into this big bar, that's essentially what Hounsfield thresholding is looking at. It's looking at the image as it comes through and seeing how dark or light it is, and then assigning that voxel a value, which is called a Hounsfield unit. So starting with lung density analysis inspiration, this is looking at Hounsfield thresholding on an inspiratory only CT. And you can already see the difference. On the left-hand side, we have an original grayscale CT series. And on the right-hand side, we have the LDAI overlay. And this is allowing us to look at fully automated detection and quantification of low density tissue, which would be indicative of not necessarily emphysema, but also parenchymal destruction, but also high attenuation areas as well, which would be indicative of interstitial lung abnormalities. LDAI can be utilized for population health, and it can also be complementary to lung cancer screening. And so many of you out there might be asking, well, why would we want to know about emphysema and interstitial lung abnormalities from lung cancer screening? Well, LDAI gives us the ability to gain additional insights into essentially not just lung cancer screening, but any inspiratory chest CT. And this is just an example from the National Lung Screening Trial. There were participants that had major smoking-related conditions, and there were 53,000 participants in this study. And they were essentially looking for lung cancer, and they found some. 2.5% of them had lung cancer, and 70% of them were at stage 1 or 2. But what they also found was that 30% of the people that participated in this, they found that they had measurable emphysema, and 82% of them had no prior diagnosis of COPD. And on top of that, they also found they also had coronary artery calcification. So they had heart problems as well that still had no diagnosis. So we know that screening saves lives, and the NLST was able to show this. There's a 20% mortality reduction from being screened, but smokers develop and have mortality from things that are different than just lung cancer. And so LDAI is also the technology for those of you out there that are familiar with interventional pulmonology and the treatment of Olympus spiration valves for emphysema. LDAI is the foundation for which the Olympus Select report generates the quantitative CT results to be able to determine if a patient meets the criteria for even receiving that treatment to begin with. LDAI also has the ability to generate customized reports for smoking cessation. So this actually generates it where it's now a patient-facing report where a physician can actually hand their patient this piece of information and say, you know, Larry Doe, these are actually your lungs. This is what they look like. Black is bad, pink is good. And we have this in two different varieties where you can show if you are remaining a quitter, this is the benefit you would have to the longevity for your life. Or there's also another version where we can show you to motivate somebody to quit, what can happen immediately, week 1, 6 months later, 1 year later, if you quit smoking. And so this was actually presented at CHEST in 2022. There was a version of this smoking cessation report that was given, and the conclusion essentially found that this was the equivalent to a 45-minute smoking cessation treatment therapy session. It caused people to think about quitting smoking earlier, and they wanted to quit and last longer after they had quit. And both the National Institute for Healthcare Excellence and the Global Initiative for Chronic Obstructive Lung Disease guidelines cite smoking cessation as the intervention with the greatest capacity to influence the natural course of COPD. So if we take LDAI one step further and we add the expiratory phase to the chest CT, now we can even look a little bit further. And again, this algorithm also utilizes Hounsfield thresholding. So this is also based off of artificial intelligence. So now not only are we looking at the inspiratory phase, but we're also now looking at the expiratory phase of the chest CT as well. And you can see the visual comparison, grayscale series on the left to the structural overlay on the right. And this allows us to get advanced COPD analysis, which also allows us to capture early error trapping, but also look at late stage emphysema. And so what would be the utilization for this technology? So I'm going to show everyone here an example. So standard clinical assessment, we have 4 subjects. They're all gold 2 severity, and this is based off of their FEV1s all being in the low 60s. And so now I'm going to give you coronal slices for each one of these patients. And so we're looking across subject A, B, C, and D. And when we're looking at this, when I've talked to pulmonologists in the past, if I was to just stop here and I was to tell you, based on just this information alone with their gold scoring and the FEVs from the pulmonary function testing, and this is what their lungs look like on imaging, how do you treat these patients? And most I've talked to, they said, well, if this is all I had, I'm going to treat them all the same. And so that's where functional lung density analysis starts to change some things. So now we can actually see that of all 4 of these subjects, even though they're all grouped as gold 2s, the localization for where their diseased tissue is inside of their lungs is very different. So they're actually 4 separate phenotypes of where the disease is the most severe across all of these patients. And then LDAF has the ability to do something that radiologists can't do on themselves, and pulmonary function testing isn't going to tell us, but we can actually quantify what types of tissues and where are they based on LDAF analysis. So this would change how we're looking at treating these patients. So subject A, we have mostly normal and functional tissue, a little bit of persistent destruction, smoking cessation therapy if we haven't already, and perhaps COPD management. Subject B, a little less normal, more functional, but also more persistent. And unfortunately for this patient, there is a more homogeneous or even distribution of where the diseased tissue is amongst this patient's chest CT. So again, smoking cessation, COPD management if we haven't already, and perhaps we can try to enroll this patient into experimental biologics to slow the disease. Subject C, from a qualitative perspective, most of the disease tissue exists within the left lower lobe. So perhaps this patient could be a candidate for valve therapy as long as they meet the criteria for that valve manufacturer. They could go on to receive a bronchoscopic lung volume reduction with valves, or if they're not a candidate for that, perhaps they could move on to a surgical route. And that leaves us to subject D, where now we have this bilateral upper lobe involvement. Most of the diseased tissue is in the apices. Most of the healthy tissue is in the bases. And so this patient's a little interesting. So how do we treat this patient? Are they a candidate for valves? Do we put valves in both upper lobes? Do we just put it into the one lobe that's more hyperinflated? Perhaps this patient had come through a journey on a lung cancer screening, and they had found that there was some sort of lung nodule in the right upper lobe. So now for a thoracic surgeon that is planning a resect, and they see with their ability to have enhanced procedure planning that most of the tissue in the right upper lobe isn't really contributory to the patient's ventilatory function anyway, they're not going to have as many qualms about resecting the portion of that patient's lungs out. So now when we take mainly the two technology I've been talking about and combining both lung function and structure. So from left to right, we're going to go normal. We're going to look at gold 1, and we're going to look at gold 3. So we have high resolution chest CT. So here we have normal, we have our gold 1, and we have our gold 3. So can kind of tell maybe there might be some hyperinflation on the gold 1, gold 3. There's definitely some emphysematous tissue destruction that's occurring there, but let's take a further look and see how this is actually affecting the ventilation. So now utilizing that XV technology through CT-LVAS, we can actually see the actual distribution of the patient's ventilation throughout their lungs. And the normal patient in gold 1, not very remarkable, but you can see that there is a huge change in terms of the distribution of ventilation in this patient's lungs that has gold 3. Red indicating little to no ventilation, green being more average, and blue being areas of compensation. So we can see that there is an apical to basal shift in this patient's ventilation. And why would that be occurring for gold 3? Now, when we look at functional lung density analysis, we can see that the reason why the ventilation is shifted down into the bases is because all of the tissue has been destroyed, and most of the, if you could call it healthy tissue, exists at the bases. So the ventilation is trying to go and match where the healthy tissue is. So thinking about this and the technologies that we've shown about pulmonary diagnostics as they exist today, and some of the technologies that exist, whether they are mathematically based or AI enhanced technologies, the whole reason these technologies are here is to help us solve this kind of clinical conundrum in lung assessment, where oftentimes when a patient comes in for initial exam, we see that there may be a mismatch between their clinical testing and imaging, where either we have some overlap of features that's blocking certain things that may be happening on a chest CT or even on a chest X-ray. Pulmonary function testing may look completely normal, but the patient is still insisting that there is a problem. So again, kind of down there at the bottom, not solved by historical standard of care testing. And we need to have more structural or functional information to make a better informed clinical decision. And so now we have the ability to offer you that. We can get functional regional ventilation insight with CT-LVAS or XV-LVAS, and we also have structural lung analysis that gives us more insight into lung tissue or lung anatomy with things like lung density analysis. And applications for technologies in clinical practice, this can help answer or at least yield and give insight into not only triaging the problem, but also being able to establish a baseline and then see what was the impact of a treatment therapy for that patient, or even being able to evaluate disease progression even before it's apparent on pulmonary function testing. So looking at things like breathlessness, looking at, is it even lung related, or maybe it's heart related, or could it be other causes? Is it some type of restrictive disease, or could it be an obstructive disease? And then also for intervention and pharmaceuticals, things like lung reduction therapy, or perhaps a patient has received a lung transplant and we want to see if there is an earlier indication for rejection prior to what pulmonary function testing may be able to yield insight into. So the potential use cases for not just the technologies I showed, but all AI applications based off of lung imaging, the potential use cases are essentially limitless. And I know that most of the stuff I've been talking about today seems to be applicable to COPD, but we can definitely apply these to all the different diseases that can affect the lungs, the heavy hitters like asthma COPD overlap, obviously COPD, cystic fibrosis, COVID, long COVID, helping with surgical planning. So interstitial pulmonary fibrosis, tons of different potential use cases for these applications, whether they are, again, AI-based, mathematical-based, but all of this information is sitting there native in the data that is on imaging already. We just need the right AI or mathematical application to be able to pull that information out, to be able to give you all the information that's available to you so that we can have better informed decision-making, which would hopefully lead to better patient outcomes for the patients that we're trying to take care of. So with that, that is the end of the presentation, and I thank everyone for their patience and for the opportunity to be able to present in front of you today.